I think shifting gears a little bit, what I'm going to be talking about is potentially nothing about infections, but what all of us will have to be ready for from the point of view of data science and where we can incorporate this into our practices in the future, especially from the perspective of cornea. So I come from L.V. Prasad Eye Institute in the south, and Shantilal Sangvi Cornea Institute is the name of the Cornea Institute within LVPEI. So to give a little bit of context about what we're talking about, all of you would have been looking at the papers and seen news that is emanating that speaks about how AI and data science is going to make doctors lose their jobs and things like that. Well, nobody believes this is really true. I think what AI and data science is doing right now is it is allowing doctors to become better physicians. It's allowing them to diagnose disease faster, more accurately, and early. And you must have seen news items about Tata Memorial Hospital teaching AI how to detect cancers from histopathology as well as from radiology specimens. And there are also several companies that are coming up with screening tools that can actually look at your DNA profile and potentially detect and predict what diseases you might get in the future as well. While these are things that are currently available, you also would have seen a lot of publications about use of AI in cornea per se. There are publications that talk about how you can detect from an image whether a keratitis is bacterial or fungal. You can detect whether keratoconus is present or not. You can also detect Fuchs dystrophy from different scans and predict how it will progress as well. But also you'll realize that none of these are available for clinical use right now. And for those of you who've been following what Google has done in the past about this major event that they spoke about how you can predict cardiovascular risk from an image of the retina. And this was news that Sundar Pichai announced approximately in 2017, 2018, about 8 years ago or 9 years ago. But do we see any of this being implemented on the ground? We probably don't. And there is a reason why this is so. And the reason is because when you're trying to build a predictive model based on data that you have, some part of it is relatively easy. Collecting data from the hospital, processing it, then building the model. But then the more difficult part actually comes in testing the model, also trying to deploy it, because who will use it? How do you put it on a smartphone? How do you support connectivity? How do you support cloud costs? And to monitor the outcomes to make sure that it is performing well, and then to maintain the model as well. All of these cost a lot of money, and that is the reason why there is something called the implementation gap, that is between the publication of a model that can detect disease versus using it in patients in hospitals or on the ground, unless it is supported by some sort of funding or it is supported by some sort of commercial interest. It is very difficult to implement this in the clinics. So I'll switch gears now and talk more specifically about how this can be done in cornea. All of us know that corneal disease and blindness is a major issue in our country. Estimated that it is the number one cause of blindness in India for people who are less than 50 years, and the number two cause for people who are more than 50 years. And there are several challenges when we talk about corneal disease and corneal transplants. We have people who are unable to afford care. If they're able to afford, it's not available where they are. Access to people who are in rural areas is an issue. And then even once we provide them care, I'll show you later on that accountability on the part of the patient is also missing. So we try to put together a plan where we will look at this holistically from three different angles. So if we want to make sure that corneal transplants in India is a successful story, we said that one of the things that is very important is to try to treat the diseases that are resulting in a corneal transplant right now. So you have an infection, treat it early so that it doesn't result in a scar that requires a transplant. And secondly, after that, for those who really require transplants, put together a robust eye banking network to expand the network, enhance the capacity so they collect more tissues, so that you also have more tissues for transplant. And the third part is now once you do a transplant, this is where accountability comes in. People disappear from follow-up, they don't maintain their medication. So also enhance survival so that once a transplant is done, you enhance the number of years it lasts so that you don't have to do a repeat transplant. So this we think is going to be the way in which we can ensure that transplants have better outcomes in India. So why are we talking about this when I'm talking about technology and AI? I'll tell you some examples. Say for example, infections. We've seen that most microbial keratitis actually occur in rural areas. About one third to half of all the infections that we see emanate in patients who have a rural background. So what we are trying to do is in the rural centers that we have that we call secondary centers, we are trying to put together a system where we put together a microscope to examine these slides, and we are connecting these microscopes using an online system where a technician will be able to put the slide under the microscope, but a microbiologist sitting in Hyderabad is able to view those slides and again diagnose what organism is present in those scrapings, so you can start treatment earlier and more appropriately. So we've also started building an AI model that will be able to automatically look at these samples. So in the future, a microbiologist is not required to look at these, and they'll be able to actually, in bacterial keratitis, right now, the precision of this model is anywhere between 80 to 90%, and it's able to detect these organisms quite accurately. So we hope that microscopes will come with these kind of AI readers in the future as well. In addition to that, we've also created a very small device that goes onto a smartphone called Grabby that will help taking pictures of patients' eyes. Using this, we've been trying to take pictures of patients who have fungal keratitis, bacterial keratitis, and train a model to be able to differentiate which is fungus, which is bacteria, and which is virus. And based on this, we are getting about an 86 to 90% accuracy in the photograph and the model being able to detect whether it is fungus or bacteria from a single clinical photograph. So what we are going to do now is we're going to implement this model on a mobile phone of a health worker who's in a rural area. And so he can take a photograph of the eye, and then in consultation with a doctor sitting in the city, he'll get a diagnosis about whether it's fungus or bacteria, and the doctor can prescribe the appropriate medication based on some other factors. And then they can monitor the same patient, and then with serial photographs the model will tell whether the patient is improving or is worsening, and so you'll know whether you have to refer this patient to the city or not. That's an example about how you can use AI and technology on the ground to benefit patients. The second area that we're looking at is in keratoconus. So keratoconus, all of you know, is becoming more prevalent now, starting to appear in younger children right now, and we published a model called KEDOP, which is able to predict progression on the topography scan of a patient 40% of the times better than a clinician would probably do. So what we are trying to do with this is we've built an online model where you can upload topography of a patient, two topographies, and the model will tell you whether this is going to progress in the future or not. So you can decide about cross-linking right now, and you don't have to wait for the patient to really progress before you offer cross-linking. So what we are also doing is we are putting together a keratoconus school screening program where we're creating a mobile vehicle that's going to haul pentacams across schools in the 3 states that we're in, do multiple topographies, and try to see if we can identify keratoconus in high school children. And if we can, then we'll actually use the model to see if it is going to predict progression, and if it is, then we will offer them cross-linking on site so you can prevent progression of the disease much earlier than what you normally would. In addition to that, we are also working in the Eyebanking area, where one of the problems with Eyebanking is, you know, that anybody who wants to sign up to donate corneas has to just fill in a form and give it to the Eyebank. So what happens to these forms? The Eyebank stores them in a cupboard, everybody forgets about them, and it actually is only an event that is apparent for the patient and the family that there is a desire to do this, but it doesn't close the loop. So what we are doing in conjunction with Infosys is we built an app called Sight Connect that helps self-screening for people to see if they have eye diseases. What we're also doing here is we've created a system called Eye Pledge, where people on this app can pledge their eyes. And if they pledge their eyes, the information from this, along with their ABA number, which is generated from their Aadhaar card, will go to the nearest eye bank. It'll also be stored in their medical history. So if they eventually get admitted in a hospital and they pass on, then there'll be a trigger from that using their Aadhaar number to the eye bank, telling them that this patient expressed a desire to donate cornea, so please go and collect cornea. So at least there's a trigger and we are closing the loop. And we believe that will increase the number of voluntary donations here in the future as well using this. Additionally, using this, I'll take a minute or two more.
Yeah, we have time.
Using this, we are also trying to set up a distribution system where all excess corneas, like for example in LVP, on an average we use about 4,000 corneas for transplant in-house. We distribute 4,000 corneas externally to surgeons who use them as well. But then we are not sure about who requires them. So we are going to create a system where all surplus corneas are going to be listed on this app. And so doctors should be able to go and pick corneas for their patients and say that, hey, I choose this cornea for my patient based on a matching system, and that will be delivered to the doctor in back-end logistics. So it will be like a distribution system that will be available for everybody across the country in the future. In addition to this, apparently, almost 700 eye banks across the country have not collected a single tissue in the last 5 years. And most of the time it's because of lack of human resources. So what we are also doing is we are training a artificial intelligence model in the eye bank based on images of the cornea and on specular microscopy that will be able to grade these corneas. So you don't require the eye bank technician to actually have the expertise to grade them. You just need somebody who's an administrator to help distribute them. And so this again will be ready potentially towards the end of this year, and eye banks can start using it in the future as well. So this is the distribution system that I was talking about. In addition to this, the last part is about compliance. And this is where accountability comes in, because we see that one of the major reasons why people don't have follow-up is because of the distance that they have to travel to come back for follow-up. And we found that about 50% of our patients have to travel more than 200 kilometers to come back for care, which is a deterrent for somebody who probably doesn't have the money to pay for that transplant as well. So what we did is we also created a predictive model that can predict which graft is likely not to do well. It can also predict who is likely to miss a follow-up visit in the future and where are these people coming from. And we put it onto a mobile phone. And so using this, you can actually predict who might not come back from follow-up. And so you can actually deploy extra resources to bring them back. We've also created a keratoplasty chatbot, which again will be available for use, which is a WhatsApp-based multi-language system that patients can query. They can put their symptoms onto this, and they can also upload a picture of their eye. And using this, the chatbot can tell patients if they're having an impending problem, like if there's a loose suture, if there's an infiltrate. It will fix up an appointment to the nearest clinic that is available and ensure that the patient gets an appointment so that they can go early. So we hope that this trigger system also helps in early follow-up and recognition of problems as well. I spoke about Grabby earlier, and we also have been collecting a lot of photographs of the eye using this mobile phone imaging system. And we've been able to diagnose things like acute allograft rejection based on photos that patients have sent us. And what we are also doing is we're creating an annotation and image analysis system which will be able to automatically detect complications after corneal transplants. Earlier, right now, probably the more easier ones to detect, like infiltrates, but in the future we hope that it can also detect rejection and things like that, and be a automated remote monitoring system for patients who have transplants in the future as well. So that is a summary of what we hope we would like to do in the next 5 years, and how we would like to use technology from the point of view of surmounting all the challenges that face us in patients who have corneal transplants. Thank you very much.
Thank you, Pravin. I invite Shweta and Manisha to moderate and to ask any questions of any of the speakers still present.
A very interesting talk, sir. Even if we jump on the bandwagon or not, AI is going to be the future. But as we expand, as you saw, we saw the last slide, a network of what all you are planning to do and what the world is already doing and in the process of doing. The medico-legal aspects will similarly increase in significance, so as to say. So when we say that a patient does not have complication, or the keratoconus is not going to progress and we don't need a C3R, and the patient comes with the high drops later on. So who takes the onus of it, and how are we proposing to handle the medical legal aspects? Because the scapegoat is the doctor first, not the technology, not the app.
True. And so we're very, cognizant of this, and because of that, we've been working with lawyers as well to advise us how we should have disclaimers to ensure that doctors are not put into trouble because of this. As of now, the guidelines from CDSCO say that you can't use an AI algorithm to tell a patient what to do. It can't make decisions for the patient, but it can help a doctor make a decision, and it can guide the decision making process of a doctor. So the doctor can decide whether this is according to his clinical acumen, he agrees with it or not. If he doesn't agree, he's free to make his own decision. So the onus is still on the doctor whether he wants to follow the AI algorithm or not. Because right now the AI algorithm is not allowed to give decisions to the patients. It only is a support system for the doctors.
Because we at most lose an eye. It will be implicated in all healthcare systems, and patients will lose lives as well if we rely on AI. So that is one thought maybe that we do need to work on, who takes the fall when it comes. It will inevitably come as it
Correct. And
becomes
it will
more
be
and
the
more.
doctor at the end who is
Doctor at the end, yeah.
I'm predicting there'll be some test cases, and then based on that, the court usually then lays down the law in such. This is how it normally works whenever there's some new technology.
Absolutely right. It's actually very hazy right now.
Yeah.
Nobody knows which direction.
Yeah. So it's only when it's tested in court that depends on the judges sitting there at that time, which is for most things. Any comments from the audience? Anyone would like to?
My only suggestion would be regarding the corneal ulcer case. At least for the first visit, do not diagnose the case on the AI method or the photo. You can have it for a follow-up, but first thing, just on a front photograph, sometimes it's very difficult to diagnose and you may get wrong. So for follow-up, it may be a good practice, but for initial diagnostic, I would still suggest that at least the local ophthalmologist who is there is the best time to refer the patient.
No, I agree with your concerns, but what is published right now, I think University of Michigan have done an evaluation where they found that the AI model is outperforming cornea specialists in being able to diagnose the infection or what is causing the infection from the photograph itself. In fact, it is even better than the microbiologist in being able to diagnose infection. So it's based on that we're trying to see, because in rural areas you don't have access to microbiology, and only clinical acumen of a doctor who's present in a rural area might not be good enough, which is why we think this can be an augmentative technology that will help.
Augmented thing, but still I would feel that it has to be with the local practitioner. That's my personal view.
So when we also did similar studies, collecting data and my team, and that's why we were very keen to understand what is happening. We have also found that when we were looking at and did some kind of sort of study, that AI was performing good when it comes to the first visit and trying to. I mean, as clinicians also, 80% we are able to say that this is not. 20% is we also don't think so. As specialists who's been into practice for 10, 20 years, also we can always have that last minute. But I understand what it is, but it's coming out to be okay. The results are looking pretty.
Yeah.
No, it's just about, I think what his concern is about undermining the microbiological aspect to it.
Yeah.
Also, the AI is just going to be with the front photograph, nothing more than that. So we need to have a slit lamp examination. We have to see the anterior chamber. We have to see the type of ulcer, whether it is raised or depressed, what other factors, and then so many other things which are involved while treating an ulcer, which this simple photograph won't be able to get.
Yeah.
That's another concern.
So from the perspective of a cornea specialist, it is inadequate.
Yes.
But from the perspective of somebody in a rural area on the ground, it is definitely more than what they have
We
right
can
now.
augment both of them together.
Sure.
With the help of local
My only issue is that for decades now, from this forum and from every forum possible, we've been trying to tell residents and new corneal surgeons to scrape and
Correct.
scrape. And when this comes in, they might turn around and say, what nonsense have you been talking? We don't need to scrape anymore. So I hope there is a happy marriage and people just don't give up scraping.
No, this model can also be used that you scrape and just
Validate.
clean it and send it for AI.
Yeah, I think the first thing where they spoke about the microbiological slides, that was something which was really nice. I think that's something that will really help, because scraping probably is something which can be done by a local ophthalmologist, and that will take care of the concern that he was saying. And
But
I think as
interpreting
any
a
other
scrape again
technology,
is where AI might help.
exactly. The
Prove
first
superior
aspect
to
where
a
you spoke about the
microbiologist.
microbiological slides being assessed by a remote microbiologist sitting at a center. I think like any other technology, every technology has its teething problems, and we all learn on the way. It's like, when computers came in, everybody was told that, people are going to become jobless, but they just introduced new jobs in the market. It was just a shift. So I think AI definitely is something that all of us are looking at. It's not something which is bad, but it's just that we all have to learn and on the job, get better at it. But some really nice projects, Dr. Pravin, congratulations for that.
Yes, Kirti?
Wonderful talk and
Thank you.
great job. I always have a concern that whenever AI comes in glaucoma or myopia, it's not about people becoming jobless. It's about our diagnostic ability becoming eroded, because our dependency on machine learning becomes so much that our diagnostic skills become eroded. So it's not about that you will be out of a job, but that you will be less competent. So that is my inner fear, that, and I'm seeing it in the residents, the dependency on OCT, the dependency on so much. The clinical skills are being eroded. In the last 20 years, I've seen that happening. So since you talked about closing the loop, somewhere, since when you are designing it, let the discretionary, let the power, because the accountability also comes in that way. Let the deciding factor still be the doctor, because that will not only ensure that we still keep honing our clinical skills. This is our aid, this is our help, but it is not deleting the person's brain from it, because otherwise we will lose our competence. Not that we will become redundant, but we will be less than what we are.
No, I think that is how things progress. Like several years ago, I think the ability of the previous generation to find directions to go to a place was phenomenal. Now the current generation probably will
Google.
not be able to
Google
function
Map, yeah.
without your Google Maps. So I guess that is the natural progression, and we can't halt it,
No,
unfortunately.
nobody's altering it. I'm just saying in the close the loop algorithm,
Keep the doctor as
if you
part of
could
it.
just keep that aspect still open and not just say, okay, everything is
Yeah.
cut and dry and done, and you just need to press the button and it will give you. Don't do that, because that will be a little
So
dangerous.